in Alberta recently, you were seeing with Alberta Health Services, it's no longer going to be a whole of government approach kind of thing. It's being fractured.
Yeah.
I don't know. Any reaction to that change? I mean, I guess in theory, I kind of understand why maybe they want specific focuses on mental health and continuing care and that sort of thing, but not having it under one. I mean, it took a lot of effort to merge the regional health authorities into one health authority, and I know that
I was
Ontario has recently tried to adopt that model in Ontario Health, and now Alberta seems to be retracting from that. So, and I know like from a I know there's been a lot of positive attention in the past about like Alberta has been a good model to kind of move towards. So it just seems kind of backwards to kind of split it up a little bit here. But any reaction to
Well,
what's going on?
I was certainly involved in Alberta before the regionalization, then the first regionalization, and then the Big Bang when all into one. So I've kind of seen the evolution. I think it was fair to say before the dismantling. Alberta Health Services was the most highly performing system in the country. The administrative costs were low compared to anywhere else in the country, and they had some of the integrated care that they are doing is quite was quite remarkable. I'm not a big over the years I've been less and less enamored with structures per se. I think it's too easy to assume that a structure is going to solve your problem.
Sure.
But unfortunately, structures are easy to change. So, it's political. You can wipe them out in a minute.
Yeah.
But the problem with that is, number one, you're telling the public that you really don't know what you're doing because you're changing something that you supported originally.
Mm.
And number two, you're creating a level of confusion among the people who work in the system that they don't need. But I look at a province like British Columbia, who has really, they created those regions back quite a while ago now. They haven't changed them at all. They've done some tweaking, but they've left it alone. They're focusing on internally, what do we do to get better performance, which is, I think is the way to go. I'm dating myself, but in the late 80s, Alberta, under Ralph Klein, we did the Rainbow Report was produced, and
Mm.
it talked about some of the key issues. And a couple of the key issues was lack of integration and lack of coordination. They came up big time, and particularly with seniors, children, and mental health.
Mm.
And so they were drivers of the integration. So I was kind of interested to say, well, the rationale for integrating is now you're using as the rationale for disintegrating. So I think you can disconnect these groups, but the point is where you always have the barriers are at the point of connection. You look at this most recent incident in Edmonton with the patient being discharged,
Right. Yeah.
to that. Well, now it's two different setups now. They're not. It's not all part of AHS. Once they go out the door, in this case it was the Royal Alec, I think. But once they're out the door, they're not. They're not part of the reconfigured AHS. So I think it makes. I think when we create structures, we have to look. Does this really? How is this in the best interest of the patients? That's
Yeah.
really what we think it's all about.
Yeah, and on that patient front, I don't know if this is the case, but if they're now not in the realm of AHS care, the system's potentially losing sight of that person, right? As a
Oh
whole.
yeah,
Yeah.
now you've got to worry about creating a whole bunch of connections that were there before. So I think it's a challenge. I don't think there's, as I said, I don't think there's anything that you look at where you say that a structure is going to solve your problem. Everything's going to be fine now. It won't.
I feel bad for the folks, and I imagine this exists at most health authorities. But I feel bad for the staff, like especially AHS. Like they've gone through so much change since 2009, whether it be changes in the board every year or changes in their executive leadership. Like I imagine it'd be really tough for middle management and for frontline staff to kind of go through all these changes.
Oh, I think so. And I think, I'd hoped during COVID in particular, that the healthcare system would realize that it actually is a people business.
Mm-hmm.
And you can't do anything without people. If you don't have people, you can't provide a service. That's it, point blank. And they have, I think, for years, for decades, we've often talked in healthcare. When we talk about our people, we talk about them in terms of their bodies that fill slots in a timesheet or collective agreements, not about the fact that these are without them, we can't. Not only can we not provide service, but how we think we're going to provide quality service. I mean, the linkage between quality of the service provided and the level of job satisfaction of the providers is quite well known.
Yeah.
And so if you get I mean, I think one of the things I've said about healthcare that's really probably one of its defining characteristics is most people who go into healthcare go into it because they honestly want to make a positive difference in the lives of other people. You
Yeah.
don't see that in most industries. They're generally all aligned, whether it's the housekeeper, the registered nurse, the physician, you name it. So what is it? What is it that we're doing in the system that doesn't allow them to do that and creates this high level of dissatisfaction? But I think then, to turn around and then say, okay, we're going to throw everything up in the air. We're going to come up with some harebrained idea to do something, and then wonder why our people are leaving. Well, hello, they can go elsewhere now, and not even can they go elsewhere. They can go elsewhere in Canada, can move
Yeah.
around. They can go elsewhere in the world. I mean, in
Yeah.
healthcare, the shortage is international, and
It's
it ain't
global.
going
Yeah.
to be fixed in the next decade.
Yeah.
And so to think that you can do a few things that might like increase salaries, but don't bother with the working conditions, it's not going to work.
On the AHS front, really quickly, what do you think Albertans should be looking out for, like going forward, as this sort of restructuring or sort of disassembling is happening? Like, what would you, if you're a resident, kind of be evaluating or looking out for?
Well, I'd look at the level of satisfaction, clients, patients, whatever. But I'd be looking at what are the what are the misses or the disconnects, whether it's in mental health, somebody's institutionalized and then all of a sudden has to go to the community,
Mm.
or children. I mean, any of the specialty stuff. Now that it's all split up, what do are there increased wait times? Are there levels of dissatisfaction? Are there misses? Are you like doing something where somebody is discharged and not followed up or things like that? So I think it's going to be a lot of diligence around how is the system actually performing, and is it actually cost effective,
Yeah.
and not just having somebody tell you it's cost effective, but having some good measures to be able to do that.
That's great.